with their own money. It also denies funding to organizations that advocate for access to abortion services, again, even with their own money. In the past, the Mexico City policy had applied to U.S. family planning assistance. Now, under the Trump administration, it applies to almost all U.S. global health bilateral assistance, including PEPFAR. So the reach of this policy has been greatly expanded and has the potential to roll back the progress on HIV. So our first speaker is Jennifer Cates of the Kaiser Family Foundation. Jen will share analysis of the impact of the newly expanded global gag rule on organizations receiving PEPFAR support. Jen, please go ahead.
Thank you, Anton. And thanks for providing an opportunity to present our new research findings on the Mexico City policy and PEPFAR. For this study, we sought to estimate the number of foreign NGO recipients of PEPFAR funding who could be subject to the policy, as well as the amount of funding they receive. To do that, we analyzed U.S. government data for a recent 3-year period, 2013 to 2015, and our goal was to identify the number of these foreign NGOs that were recipients of PEPFAR bilateral HIV assistance in that time period. We also looked at the countries in 2 groups. One group that has legal abortion in at least one case that was not permissible under the Mexico City policy, and then those that only allowed for abortion in cases that are also permitted by the Mexico City policy. Our results in brief. We identified 470 foreign NGO prime recipients of PEPFAR funding in that period of time, and I'll come back to why that's important that they're prime recipients in a moment. They accounted for about $900 million. So those prime recipients, those foreign NGO prime recipients would have to decide if they were going to accept PEPFAR support and certify compliance with the policy, or not accept support and not receive PEPFAR or other U.S. government funding. We also found that there were 264 U.S. NGO prime recipients of PEPFAR funding, totaling over $5 billion, who, to the extent that they granted or had a cooperative agreement with a foreign NGO, would have to ensure compliance with the policy. And we do know that a lot more of the money from PEPFAR flows to U.S. NGOs at this time, and then in turn goes to foreign NGOs. We also looked at where these NGOs work. We identified their programs in 61 countries, 36 of which allow for legal abortion, and at least one case not permissible under the Mexico City policy. While this new research provides a sense of the scope of the potential reach of this policy, there are several questions that I want to highlight that are still important for us to learn about. One is, how many of the foreign NGOs that are providing HIV services and other services that conflict with the MCP, and how many would have to discontinue those services if they certified compliance? How many foreign NGOs will choose not to certify? What does the impact look on a country or sub-regional level? And how will PEPFAR's goal to increase the share of funding provided to local partners impact the MCP, affect the impact of the MCP? Lastly, and a key issue that we were not able to identify in our research, and one that is still an ongoing question, it's very difficult to identify all of the sub-recipients of PEPFAR support, which flows, as I mentioned, to many different kinds of entities, including U.S. NGOs, and then in turn goes to foreign NGOs. From other analyses we've done, that's at least twice the number of prime NGOs. So it's many, many more NGOs, and we're not able to really identify that universe at this point to understand how many might be affected. But even without those data, our analysis indicates that the expanded policy will likely affect hundreds of NGO recipients of PEPFAR support, who will at least have to certify compliance with the policy or choose not to accept the funding. Ultimately, however, it's still too early to understand the actual impact on health on the ground. Thank you.
Thanks, Jen. Our next speaker is Luisa Orza of the International HIV/AIDS Alliance in the UK. Luisa will share analysis from Malawi and Cambodia, looking at the funding that organizations have already lost due to these funding restrictions. Luisa, please go ahead.
Thank you so much, and thank you for the opportunity to speak at this session. Before we start, I'd just like to mention again that during the course of the study, we changed the country focus from Ethiopia and Zimbabwe, so our hypotheses are now based on data coming out of Cambodia and Malawi. The HIV community has expressed grave concern for what the expanded global gag rule could mean for the health and rights of key populations affected by HIV, including people living with HIV, men who have sex with men, sex workers, transgender people, and people who use drugs. Experiences across the International HIV and AIDS Alliance, which is a partnership of 36 independent organisations, includes direct loss of funding to both HIV and SRHR organisations and programming, including programming for key populations. Indirect loss of funding and capacity through burdensome admin, confusion and reallocation of resources. Overextension of the global gag rule resulting in cessation of sexual and reproductive health services, including services which are not covered by the global gag rule standard provisions. Siloing of sexual and reproductive health and rights and HIV services, and silencing of civil society to advocate for safe abortion access. Excuse me. The Alliance, with support from the Swedish International Development Cooperation Agency, or SIDA, is undertaking a mixed method site-specific study to forecast the potential impact of the global gag rule on HIV and key population services, and on HIV, SRHR, or sexual and reproductive health and rights integration. We are close to completing the first phase of this study. National level data from one of our partners shows a sharp drop in the number of people from key populations accessing integrated HIV and SRHR services from around 50,000 in 2016 to around 6,000 in 2017. That's people reached with those services. Emerging trends from site-level data show a mixed picture, which is also less clear in terms of attribution to the Mexico City policy itself. The next phase of the study will be qualitative and quantitative fieldwork, which will allow us to explore in depth the emerging hypotheses. These include disintegration of HIV and sexual and reproductive health services and an overall impact on service access for key populations. Thank you.
Thank you, Louisa. Our next speaker is Brian Honneman of AMFAR, and Brian and his colleague. Brian, please go ahead.
Yes, thank you. For having me here. So, as was just said, when the policy was expanded to encompass all of PEPFAR as well as other global health assistance, one additional provision was added, which is now called the affirmative defense. And what the affirmative defense says is where there is an obligation under local law for healthcare providers to counsel and refer in accordance with informed consent law, are continuing to provide counseling and referrals in those contexts will not constitute a violation of the policy. And this is really key because the policy is really about a speech restriction. The speech restriction is attempting to get in between the doctor-patient relationship in foreign NGOs and provision of by foreign NGOs. And informed consent, it really matters in that context, and we'll talk about this a little bit in relation to dolutegravir in a moment. So the policy says that healthcare workers puts healthcare workers in a position of potentially violating medical ethics as well as local law, particularly if the policy is overinterpreted in ways that have already been discussed, because it denies women access to information to make informed choices about contraceptive decisions, about HIV services, about antenatal services, because they're not being informed of all of their available options, including termination of pregnancy. This becomes particularly salient in the context of what we've heard about dolutegravir and the rollout of dolutegravir that is going to be going out. One of the issues of the Mexico City policy is that abortion as a method of family planning expressly includes abortions due to fetal abnormalities, and so those are expressly not allowed to be discussed in relation with patients. And it is a very restrictive definition of abortion as a method of family planning. And I think the last point that I want to make is that this is a sovereignty issue. Countries passed laws liberalizing access to abortion because they recognize the importance of abortion as essential health services for women. And particularly now in the expansion, with a lot more money being impacted with PEPFAR and all the others, a lot of organizations that used to even provide services to their national governments are no longer actually even able to take money from their own national governments to provide services that the national government itself is asking the organization to do, because they can't go out and do advocacy and inform the population about the abortion laws in the country. Thank you.
Oh, thanks, Brian. So our next speaker is Chloe Cooney of Planned Parenthood Federation of America. Chloe and her colleagues assess lessons learned from previous iterations of the global gag rule. Thanks, Chloe.
Thank you. We've been closely tracking this policy over the last 18 months, and as Anton said, with the lessons learned from past iterations of the policy. And over this week, we've been investigating the impact of the policy on the HIV community, especially as it's applying to this funding stream directly for the first time. Since arriving at this conference, we've had over 150 conversations with stakeholders. And I want to share two major findings from this collective analysis. The first, and this will echoes what my colleagues have already said, some of the greatest harms of the global gag rule will not be measurable on a broad population or national level until it's too late to reverse course. And the second finding is that a significant impact that we're seeing evidence of at this point is the stigma that the policy operationalizes. The stigma itself is a harm of the policy, especially as it interferes with sexual health, but it's also a means by which the policy hides its effects. In other words, the nature of the global gag rule is that it hides the very harm that it creates. So consequently, the global health community, and especially the HIV community, needs to pay very careful attention to the organizational and community level evidence of impact that's starting to surface, and then respond accordingly. I want to just name a couple ways that we've observed the stigma is operating through this policy. As we've heard colleagues speak of already, there's stigma just around talking about the policy. In our workshop, many organizations expressed fear in their communities from even sharing their decision about whether they would sign the policy, which undermines the ability to track the impact, but also to address potential service disruptions. And I will note an indicator of stigma is also the fact that most organizations refuse to share their experience publicly and request anonymity in discussions. And it's a fact I know is very frustrating to media reporting on this issue, as I've heard from several of you. The US government assessment of the policy, which was dangerously inadequate, is itself contributing to the silence of the impacts as well. One other issue of sort of the way stigma operates that I just want to highlight here is that every organization we've spoken to expresses widespread confusion. And alarmingly, many organizations and even US government officials believe the policy prohibits broader services than it does. So a real concern, therefore, is the overimplementation of the policy. So these effects of stigma, I think we see evidence and early signs of long-term impacts. And two areas I want to highlight specifically. The first is our ability in the HIV response to reach key populations. When service disruption is affecting those who are already marginalized and are losing the trusted provider they know, that's going to have very substantial impacts on our ability to reach that community over the long term. And the second long-term impact we need to pay attention to is the strength of the civil society sector itself, which we know is critical to the global health response. This is especially true as our field is moving towards sustainability and country ownership of health programs. It's national advocates that we're asking to hold governments accountable for their health investments and are an important piece of the puzzle in sustaining those programs. Yet in interviews, we're seeing alarming trends around the ability to organize in coalition as a result of this policy. So together, the effects of the policy, we believe, are standing to greatly undermine the global fight against HIV and ultimately the health outcomes of the community impacted by it. I do want to mention we have a call to action at this conference towards the US government to end the policy, but also to donors and other governments to take steps to mitigate the harm. Thank you.
Thanks, Chloe. Our final speaker is Tikale Tei of Malawi, and she's a global chairperson of She Decides movement, and she's going to share her perspective as an advocate working in a country affected by these funding restrictions. Thanks.
All right. So, firstly, turning away to the effect on these NGOs that have been affected by the funding cut, let's actually turn our attention to actually the lives of the girls and the women that are actually affected by this. I think the biggest thing and the biggest impact that we're facing is a violation to the fundamental reproductive health rights of every woman and every girl in this world globally. So we're at the situation of standing in as She Decides, where we've brought together a global movement which was founded and initiated by a Dutch minister, former Dutch minister, Lilian Poelman, who pretty much called together global leaders from different countries, civil society organizations, artists, private sector, to pretty much commit to a movement called She Decides, realizing that the impact of the global gag rule actually had a political leader who was a man, who decided on behalf of millions and millions of girls and women about their body and their rights. So pretty much this movement has brought together so many people. We've had over 300 organizations coming on board, over 50,000 individuals coming on board, pretty much standing, saying that women and girls need to decide on these issues. Some of the impact that you're seeing at a country level and different developing countries is that we found that, small community-based NGOs that had about 10 to 15 service providers have now had to cut to about 10, 5 to even 3. So now realizing that some of the girls that were accessing family planning services or accessing to contraceptives now have to not have those services. And that's the reality. Now we're dealing with a rise in unsafe abortion. And to be frank with you, we're dealing with girls at a community level where you're hearing cases that they're using glass, to try abort, or they're using hot oil or using sticks. And this is the impact that you're having at a community level, depriving these girls and these women to access to proper quality healthcare services and comprehensive family planning services as well. Not only that, we're also seeing a rise to maternal mortality rates because of these issues. So at the end of the day, this has called us to that urgency to say that women and girls need to decide about her body, her life, her future without a question. And as She Decides in a global movement that's come together, we're standing on ensuring that people are standing up and speaking up and holding our governments and our leaders accountable on these issues. We're ensuring that rules are changed, because at the end of the day, we're dealing with people's lives. We're not dealing about organizational objectives. We're not dealing about government objectives. We're dealing with people's lives. That's women and girls in our community. And lastly, ensuring that we do unlock the resources. Because the issue that we're seeing here is that so many NGOs have been so dependent on US aid funding. And this is a realization that our countries and our political leaders need to strengthen domestic resources as well. So a question to all the countries in terms of what are we doing to strengthen domestic resources? What are we doing to pretty much ensure that the community are informed of this impact and are actually raising their voice and demanding accountability? Thank you very much.
Thanks, Tikala. We've heard some very concerning issues around the global gag rule from our speakers, and also the impacts on community. So now we'd be very happy to take any questions that you have. If you'd like to ask a question, come to the microphone, and then could you just state your name, any media outlet you belong to, and if there's anyone particularly you want to ask a question of, please name them. Thanks. Okay, microphone 2. Yeah, please. No. Please go first. Yeah.
Thanks. Hi, Mariette Leroux. I'm a journalist with the Agence France Presse. I know this is going to seem very obvious to you, but I would really appreciate it if you could, or some of the speakers could explain how tangibly this impacts HIV and the fight against HIV. Is it about clinics being closed? Just to try and paint the picture for us who are not in the know. I have a second question, please, for Dr. Pozniak. Given everything that you've said here today, or what we've heard, why the decision to host the next conference in the United States? And are you considering the call by NGOs to move that somewhere else? Thank you.
Okay, well, this conference isn't about having the conference in the United States. It's about the global gag rule. So I don't want to take up too much of your time. We're committed to moving forward with that. We've had conferences in many places in the world where there are issues. We're listening very carefully to all the voices, and we're in ongoing dialogue with those that have reservations. So it's an ongoing process. We've got to come together over this. To make sure that the future is all around managing this epidemic and not being divided. We must come together. Okay, so let's get back to the gag rule. Can we just have a few seconds from about the impact on clinics closing, etc.?
So I can say a couple of points, and then one is we have seen clinics close. We've seen that in Mozambique and other places. And what that leads to is youth-friendly services in this particular case were being shut down, HIV testing services were being shut down, STI screening services were being shut down at a number of clinics, and really a displacement of patients back into facilities that they don't feel comfortable in, which likely means that we're going to lose the ability to recruit them into care, get them onto treatment, and save their lives. So a lot of facilities, particularly youth-friendly clinics, are set up precisely because youth don't feel comfortable going into the large government facilities, and they don't end up going into those facilities to seek out access to healthcare services, including HIV testing services.
Yeah, and just to add on to that, I think with, I don't know if this, oh, there we go. To take the case of adolescent girls and young women, often it's reproductive health providers who are the point of entry for them to the healthcare system. So that's where they're going to find out whether to get an HIV test, to get information about HIV, and ultimately get retained into care. So you really can't do sort of a substitute of providers and expect that you're going to see the same quality of care for the populations that they're trying to reach. And that's what we're seeing a lot of data to support, that key populations, adolescent girls and young women being one of them, but not the only ones, the LGBTI community, the sex worker community, whose main point of non-judgmental care and the only provider perhaps that they're willing to see is no longer able to provide the services.
Yeah, and I think just to add, just an example, we've seen, for example, Kenya, the Center of Adolescent Health has been in a situation where they were supporting 15,000 adolescent girls living with HIV, and now they've had to cut down that amount of number of girls they're supporting to about 10,000. Some are even going less than that because obviously they had to retrench some of the people that were working with them and close down some of the youth-friendly health clinics, as he mentioned.
Just wanted to add one other thing. So to what they said, I think the closing of clinics and shutting down of services is the key concern. And one of the issues that's also coming up from a different perspective is the U.S. government, including PEPFAR, is really trying to focus getting more money to local NGOs and to create sustainability and ownership in countries over time. And it's not clear how that trend, which is I think everyone thinks is a good one, to create more sustainable country-owned service delivery will interfere, get compromised by the policy. So more NGOs being asked at the local level to do the work, but if they're also in this tough situation of should we accept the funding or not.
I'd also like to just add in one point here as well, and I think my colleagues have broadly said this, but I really just want to emphasize the point that, we're working with populations that in many countries already face a criminalized situation. They're very marginalized, they're very vulnerable. And where we've built up relations with trusted service providers, it goes to the point about youth-friendly services, equally goes to the point about services for men who have sex with men, for example, or sex workers, who really are extremely discriminated in public health facilities, government-run public facilities. And so if you have a situation where a clinic which has built up that trusted relationship with that community has had to close or restrict its services, you've really just got a massive double whammy of criminalization on that might be quite a small but extremely vulnerable population. We're talking about transgender people, men who have sex with men, who you don't automatically think of because they're not going to be accessing abortions, they're not going to be accessing family planning services, but it's that integration of services that the movement has really been working towards over the last 15 years, and there's a huge evidence base to support that process. That's being undone.
Thanks.
Yeah, and the only other piece I just wanted to lift up, sorry, is just for HIV-positive women who do need qualified reproductive health care providers, we're actually disqualifying them from programs that the U.S. is supporting, and that's very alarming as well.
Yeah, a lot of big concerns, sir.
Thank you. Rinke van der Brink from NOS News in the Netherlands. Mr. Horneman, I frankly didn't get the kind of escape you seem to give from the gag rule. So can you explain it again, please?
Yeah, so the affirmative defense says that where under local law, healthcare providers are required to counsel and refer for abortion as a method of family planning, they can continue to do so, and it won't be considered a violation of the policy. And what that really is about is informed consent. And in the particular circumstance that we look at, which is really looking at South African law, the South African Constitution has very clear provisions in the Constitution. There's very clear informed consent guidance in the National Health Act of 2003 that really articulates that any patient has to be informed of all of the diagnostic and treatment options generally available to a user, not just about the single service that's being provided, but about the array of other services that they could choose if they want. And the point here is informed consent then requires healthcare providers in South Africa and in other countries to inform women of their right to access abortion under the law in the country. And so that will not be considered a violation.
Which other countries?
It depends. We have a rubric of how to assess local law that looks at the legality of abortion, looks at how you assess statutes and constitutional provisions and ethical guidelines, looks at conscientious objection. And then, so there are places in Mozambique where we feel it would be comfortable to push on that, but a lot of the legal systems are not quite as clear as South Africa, and I think we need some example out of there.
Okay, thanks. Please.
Thank you. Good morning, everyone. My name is Nicolas Rodriguez, journalist from El Salvador. Regarding to the word that Chloe said about it's getting more hard to get in touch to reach the key population, let me give one opinion, and maybe you can give me feedback about that. But for example, in countries like El Salvador, not all the LGBT community are also well connected with the NGOs. Plus, for example, we as an LGBT media, and all the LGBT, mostly millennials, are connected with us because they ask us every day in inbox question, and we do our best effort to redirection this question to the NGOs, but not always are well connected. And for us as an LGBT media, it's frustrating that we working in HIV field from more than 1 decade, but we never could get like funding to do our work as media because we are not NGO, we are an enterprise. So for example, we lose great opportunities to do development for LGBT fight or for HIV response. We have a good chances, but we cannot take it. For example, let me put one example. In El Salvador, one stop bus costs $150 to a public price. But for us as a media, costs us only $15. We can do big campaigns, but still we need some resource to do that. But because we don't are NGOs, we cannot do that. We do our best as possible, but it's limited.
Yeah.
So.
Well, I think what. Thank you for that story, and I suspect there are donors listening in who will be contacting you about what work you can do. But I think what you're getting at is a larger issue, which is, the HIV response, it's still an emergency, and we shouldn't be disqualifying good providers, anyone really, who can serve the communities who need it. We really need every tool in the toolbox at our disposal to have the most strategic response possible. And this is a policy that is, with very bluntly dividing out those who can be part of the response. And I think that's the real alarm. And that's, that takes shape in many different ways, but at the end of the day, we really need everyone who can do good work to be there. I also just will flag El Salvador is a good example of a country where the abortion laws are very criminalized, so you don't see providers who are in a situation of being able to provide safe and legal abortion. However, there's a very active civil society advocating for the legalization of abortion in El Salvador, and I think we've all seen the horrifying headlines about what's happening to women in that country, in your country, and those organizations that are participating in that advocacy are disqualified now from U.S. government assistance, and that's very alarming.
Okay, thank you.
Hi, I'm Howard Armstead, and I've been HIV positive for 34 years. I'm an AIDS researcher, but I'm here representing the Public Eye newspaper from Lesotho. And I'll address my question to Dr. Posniak, but any of you are welcome to answer. And in relation to the gag rule and termination of pregnancy, recently the world has seen the rise of the Zika virus. The Zika virus may be down for the moment, but that does not mean it's out. Just like the Ebola virus, it can be coming back again. And there's a commonality between HIV and Zika and Ebola, and that commonality is selenium. I have that in my paper that I've distributed at the conference here, and also my advice to the Brazilian Ministry of Health related to Zika. And so the question about pregnancy is with the microcephalic babies that are born that will never have a life that's worth living and will be an expense on the system. How does a gag rule relate to that and the difficulty? Because that's in Puerto Rico, that's in Florida, that's in Texas, it's in America. So how are they dealing it within America? And will they refuse to deal that in the rest of the world? And after I've attended 27 international AIDS conferences and another 25 national AIDS conferences, mostly in the US, I wonder why there's never been, and this is for Dr. Posniak, why has there never been a single panel to discuss selenium that we know is in every cell of your body, concentrated in the cells and the organs of the immune system, and is a key to the immune system? So do we only talk about virology at AIDS conferences or
thanks
immunology?
Very much.
Thank you.
It's a long question.
That's
I'd like to give them brief. So I'll just say that thank you very much for your comment about virology and selenium, but this is about the gag rule here. So, but we have a conference coordinating committee, and we will take your view seriously and look at that. So I think to try and turn this into something that the panel might want to answer is obviously, to diagnose a baby like this, you need an ultrasound or some other modality. But in those countries where that's happening, and there is perhaps a choice that a woman wants to make to terminate her pregnancy because she has, and in general, a fetus that will not survive, what is happening is the same rule applied to those women. So if it is, then it's just general for an answer to your question.
I'll start. In short, yes, to the extent that the U.S. funding streams that are part of this policy, which is the development assistance that goes for health, to the extent that that funding would be provided to an NGO in any of the countries outside the U.S. That are doing work to educate women about what Zika could mean, about getting pregnant and what they're, yes, they would not be permitted to discuss this as an option related to Zika outcomes. So it is a conflict with that. You mentioned what's happening in the U.S. and Florida and Texas. That is a whole other system of laws and policies and funding. So it's a little bit different, and that's probably a subject for another press briefing at some other point. But yes, in short, where that funding is provided by the U.S. government through global health assistance, if it goes to an NGO and that NGO wants to advise women about what Zika could mean, they would not be able to provide that information at the full range.
And And I just want to add on to that it also means that the providers who are committed to providing women their full options and therefore are not taking U.S. government funding are now not available to serve women in Zika programs through U.S. Global Health Assistance. And in many cases, those are the most qualified reproductive health care providers. So I think the issue for women who are at risk of Zika is they really need counseling on all their options, and that includes maternal health support, that includes contraceptive access, and that includes full pregnancy options. And the providers that are best able to do that are, by and large, the providers most disqualified by this policy.
And as we've said, the impact on HIV and AIDS services are potentially enormous, as well as you mentioned, Zika, etc. So we have another question, one.
Yes, thank you. Sorry, I just want to be sure that I understand these funding cuts. Have they already started filtering through? I mean, have they already started happening? And if so, why are we dealing only with proxy estimates here? Don't we have any kind of a global analysis of what has happened thus far?
So the way that the policy, and I'll let others jump in, the way that the policy actually works is when a new funding agreement is let by the United States government, a new grant or a new cooperative agreement under these funding streams, that's when an organization will have to decide whether or not to accept funding, or if they have a long-term agreement and it's additional money is provided through it, so some change in an existing agreement. That's been happening on a rolling basis, and so it doesn't all happen at one point in time. So part of it is that when the policy got first announced in the spring of 2017, there was almost like a full other year before most of the areas would be touched, but it also filters down. So as I mentioned, one of the difficulties in measuring it is not just that the money goes to a prime recipient. That money then goes to subrecipients and subrecipients who also would have to make that decision. Getting a full accounting, there's no data system that has that full accounting across all of the funding streams. So the U.S. government hasn't assessed it. I'm not aware of anyone who's been able to assess it at that broad level. And then the effects as they're felt on, each of those recipients has to make a decision. Do I accept the money? Do I not? There is information on the few that have publicly been willing to say, we are not accepting the money and this is how much money we're not taking. But that's not widespread available information.
And I can just add in on that. So one of the other things, to Jen's point, on the rolling aspect of this, also USAID was really the only agency that had a lot of familiarity with this policy in the past, and so they were able to move faster than some of the other agencies that had to go through some of the rollout and learning what the policy was and how it would roll out. So that's CDC, a little bit of DOD, and NIH funding. And then the other thing that I would say is, to Jen's point about the sort of silent nature of this, a lot of the prime partners do not want to talk about the fact that they have lost sub-partners because it will put a target on them, right? And that is part of the concern as well, is nobody really does want to speak about this policy and the ramifications that it's having. And so getting through that network of different relationships that have been severed and not severed, and even the sub-partners are afraid to speak because they don't want to be flagged as non-compliant long-term.
And just to add, I think I mentioned the confusion surrounding the policy, which is really exacerbated by stigma because no one wants to talk about it. When, as Jen described, the layers and layers of subgrantees, when you're imagine that a U.S. government official working at a country level or a prime grantee may have some confusion about the policy. Imagine, 3 to 4 levels down, a community-based organization that's never heard of this. We don't know what their decision's going to be. They don't even know they have to make a decision necessarily yet. And we've heard stories of partners getting 2 business days notice to have to make a call on it, and they're still wrapping their head around what that even means for them. So the level of confusion and stigma really does make it impossible to do a full accounting at the start.
When the policy was last in place under the George W. Bush administration, it took about 2 or 3 years at least for any impact to be able to be assessed.
One last thing, just to Chloe's point, sorry. The policy also has not really been translated, and the online materials about the policy into a lot of the languages that the small local organizations are really working in, it's not even available in sort of language.
Okay, last question, because we're running out of time. If you could make it brief, thank you.
Thank you very much. Steve Morrison from CSIS, and thank you all for the work you've done in these presentations, which are very illuminating. But it's very clear from what you've said that it's early days and it's very difficult to make big categoric conclusions around what the true impacts are or will be, for all the many reasons that you've each explained. So looking ahead in the next 2 to 3 years, what is it going to take, do you think, in order to capture what the true impacts are going to be? Because I expect it's going to remain, all of these barriers are going to remain. The scale and scope and complexity of all of this, the fact that many of those making decisions don't want to disclose the decisions that they're making. So what is it going to take as researchers or as folks who are attempting to capture what the true impact is, so that we're not in 2 years or 3 years' time still scratching our heads saying, not really sure what this means?
Yeah, I mean, I think, Steve, you're raising sort of, as I would say, the $9 billion question. I think I'm going to answer it on 2 levels. One is that we do need to look at community-level data to understand this, and organizational-level data, and not discount that as somehow not as illuminating. In fact, it's the most illuminating, I think, story we'll see is really what's happening with individual populations, and we have to extrapolate to know where to go. And let that be the guide of sort of where the research agenda follows. It's not going to happen through just broad numerical data. We'll miss the big picture, I think, before it's too late. The second thing I want to say, though, is I want to challenge us not to wait to know what the impact is before we try and reverse course on it. I think, as I said from the start, sort of our number one finding in this process so far is that the true impacts of this policy won't be measurable in a quantitative, broad population way before it's way too late to reverse course on the damaging trends it's had. And I don't think it's, impossible to really predict out some of the issues that we've been raising, because we are seeing the trends. We should be taking steps to very dramatically and aggressively address those issues, and not wait for people's lives to be at risk before we decide it was harmful, and look at ways to try and undo that damage.
There are several research efforts that have already been started that are in the field now that are looking, I'd say mostly country-based studies that are doing in-depth qualitative and quantitative research at the country level. So that's one. And then second, just stepping back from my perspective, this is my 11th International AIDS Conference. I'm happy this time around to join the IAC Governing Council for the first time. And stepping back, I really see the next frontier in our battle is the no one left behind. So it really is that it might be small numbers that we are able to identify as being impacted by this policy, but I think in the sort of under the guise of no one left behind, that's really where we have to sort of tease out how this policy might be having an impact. It may be in a few countries, in a few parts of a few countries, and for a few clinics, but it's really the populations that we need to reach to reach the end of the epidemic as a public health threat.
Yeah, and just to add on that, with something like this, I mean, the impact is different in every single country because contexts are very different as well. So I think the starting point is what everyone else is saying, that analysis pretty much needs to start at a country level and to really understand who's been affected, which NGOs affected, and taking it pretty much from there. I think doing a whole global analysis is going to help. We're going to miss some information on what's happening on the ground and at community level. So I think it starts at the country level.
Okay, we got 1 minute left, so the briefest of question, and you're allowed to have the briefest of answer.
To Tikala Itaye, can you tell us how much money has been promised to She Decides and how much is effectively on the accounts of the organization, please?
Yeah. So as She Decides, last year we were able to mobilize approximately 450 million euros. And with that had happened, it was pretty much different donors that were making that commitment and private sector. And they had that decision to pretty much, support different NGOs that were impacted, institutions that were impacted. So direct funding was going directly to those that were affected by the funding cut. So, I mean, as She Decides, as a movement, we are a movement. We can't really give you direct facts to tell you which donor gave to who, but we, as the movement, we raised 450 million, and the current donors and the private sectors are giving to their respective entities that were affected within their own systems.
Okay, thank you very much for coming to the press conference. I'd like to thank all the panelists, and I hope that you've gained a lot of information about this very, very restrictive rule. And thanks so much for presenting your research here and for the voice of community. Thank you.